Greetings and good morning to everyone. Welcome to another episode of Oral Pathology Tuesdays. It gives me great pleasure to welcome all of you here. Today we are going to be talking about maxillofacial fibro-osseous lesions, and the person who is presenting today's webinar is an old friend, Dr. Simarpreet Sandhu. She has achieved a lot, and she is the professor and head department of oral and maxillofacial pathology at Genesis Dental Institute. She is currently the Secretary General of the Asian Society of Oral and Maxillofacial Pathology. She has over 80 publications, contributed to many textbooks, been nominated as the member of National Academy of Medical Sciences. I have the great pleasure of welcoming Dr. Simarpreet. Hi, Simarpreet.
Hi, Mandana. Hello. Hi,
Hello. Yes.
everybody. Hi, Mandana. Thank you for the kind words. Love for the bone pathology started because I got married into an orthopedic family, and my father-in-law has always been referring cases and came across a lot of them. But I'm sure I've tried to compile the best of my knowledge, and I'm sure I'm going to learn a lot from this platform. So today the talk is on the enigmatic fibro-osseous lesions, and I've attempted to present an update. Now, the term fibro-osseous lesions, as we all know, is a generic designation of a group of jaw disorders which is characterized by replacement of bone by benign connective tissue matrix. The matrix displays various degrees of mineralization in the form of woven bone or cementum-like round acellular, intensely staining basophilic structures. Now, if we go by the definitions, now these are the diverse group of processes that are characterized by replacement of normal bone by fibrous tissue and contains a newly formed mineralized product. I think we all are aware. So the lecture is going to be a combination of what we already know and updates from here and there amalgamated so that in the end we have an overview which will aid in diagnosis and subsequent management. Now, the designation is not a specific diagnosis, and I think you all are aware, and describes only a process. So the fibro-osseous lesions mainly are under three main categories: developmental, reactive, and neoplastic. This is what we all follow. And now they kind of shared the microscopic features, especially of the jaw, facial bones, and skull bones. But some BOFLs of the craniofacial complex are unique to that location, whereas others are encountered in other bones or the other regions also. Now, most of the benign fibro-osseous lesions, they share many histopathological features, and some non-fibro-osseous diseases also may mimic. So that is where the problem starts. So the definitive diagnosis, obviously, it requires correlation of histopathological features, clinical, radiologic, along with the clinical, radiographic, and of course, very important, the intraoperative findings. So classification, if we talk of the first, option, that is the classification of BFLs, has always remained a challenging task, both for the clinician and the pathologist, and has therefore been constantly subjected to frequent reclassification and renaming. We've approximately had, from the past 3 decades, we had several schemes have been proposed, and this was a bit to guide diagnosis into appropriate management, but still classification of FOLs remains a very, very challenging task. So here are the few classification systems that have been listed here, which we're briefly going to go one by one through them to have a view. And Cook in basically, first we started with Cook, and he classified in 1957, and then we had the WHO classification in 1971, and which was again revised in 1972, but the WHO classification overview, I'll take it later down the slide. And then we had the fibro-osseous lesions as given by Charles Waldron, and they were classified into developmental fibrous dysplasia. And then we had OF, that is ossifying fibroma, and cemento-osseous dysplasias were categorized as being of periodontal ligament origin. Then we had a working classification by Miko and Melek, and then we had the next by Slutweg and Mueller in 1990, which was followed by a modified Waldron classification of the jaws in 1993. Now, in order to overcome the demerits of his own classification, Waldron reviewed the subject of fibro-osseous lesions in 1993 and suggested a modification. So you had fibrous dysplasia, cemento-osseous dysplasias, and basically the fibro-osseous neoplasms, in which cemento-ossifying fibroma was part of it. And this kind of became the most acknowledged and applied in practice classification, which also set. And then there was Brennan and Fowler classification. Believe me, there's so many, and they modified the Waldron's classification, and they suggested the fibro-osseous lesions to be categorized into, again, fibrous dysplasia, and they used the word osseous dysplasias, and they categorized into periapical, focal, and florid. And this was followed by now, with the systematic application of this application, our understanding of the radiological presentation and clinical features of these lesions, as well as applied therapeutic approaches, evolved. For instance, while radiotherapy was an accepted treatment for certain benign fibro-osseous lesions in the 1940s, it is now known that it causes sarcomatous transformation. So it is contraindicated now. So this is the WHO classification of 2005, the widely followed classification. And for this one, this was an attempt to unify various classifications. The World Health Organization came up with the objective histological definitions of tumors, which will facilitate the wide adaptation of a very uniform terminology. The core of this classification is the concept of a spectrum of clinical pathological entities, and made because they considered clinical, histological, and radiological features. And this has been kind of a lasting authority because we keep going back to the 2005 classification. Then it was changed by, again, Paul Spate and Roman Carlos. They made a classification based on the new WHO classification. Waldron, Slutwig, Brannan, Fowler, and Elmofty also contributed. A number of workers have tried to clarify the classification of the lesions. And we had two new categories coming in: the juvenile trabecular ossifying fibroma and the juvenile subamoid ossifying fibroma. Then this was Eversole. And based on the most recent WHO classification, has again seen a change in 2017. And here I've attempted to put the four WHO classifications, which include the first edition, in which cementifying fibroma and ossifying fibroma were two separate entities. And again, in 2017, cemento is a benign mesenchymal odontogenic tumor, and the cementifying fibroma is descriptive and the lesions which are specific to tooth-bearing areas, and they are distinguished. They have to be distinguished from the two juvenile variants. So again, this is an overview of, and I won't take much time because I feel the classifications, believe me, when I was even compiling, are very, very confusing. What is more important is that we have an in-depth knowledge of the nature of the lesion, the clinical features, and of course we can follow any classification that we find from the letter of the 2005 or the 2017. But what we have to be very, very aware of are the various clinical, histopathological, and the radiological presentations, so that we can discriminate between the different lesions, because the treatments obviously and management varies, right? So now we know, this is again going back to what we've already learned. The fibrous element variations are, it has homogeneous plump monomorphic fibroblast. It could be hypercellular or thin collagen fibers, or mature hypercellular or fasciculated storiform. As far as the ossification, there are a lot of variations. There could be metaplastic bone formation, which I'll be taking up further as and when the lesions evolve. The Chinese, which we all know from third year, the Chinese pattern, the lamellar bone trabeculae, osteoblastic rimming, mosaic resting reverse lines, trabecular paralleling, cemental woven, curvilinear conglomerates or ginger root, and we have droplet or summer and Sharpe fibers fringe. Now, the final diagnosis, I've already said, has to be very careful, have to be very careful to correlate the clinical history and presentation with the radiographic appearance and intraoperative findings, and of course, the histopathological features. And important elements that need to be considered are age of the lesion, the gender, the ethnic group, lesional sites, and the distribution, because all these make a huge difference. And that's how these are the various parameters we consider to delineate the lesions into their categories. And these are the histological patterns of the fibro-osseous lesions. Like I said, that the woven bone or the Chinese lettered appearance, which we are very, very aware, all the histopathologists, oral pathologists are very, very aware from third year onwards. And then you have a bland spindle cell population, which is mixed with various amounts of woven bone. And then you have abundant woven bone. And then you have globules of osteoid in a loose, fibrous tissue background. Now, for the radiological patterns, very briefly, fibrous dysplasia, you already know, is poorly delineated and involves large expanses of the craniofacial bones. And this pattern should be correlated. You have to be very careful for the presence of other lesions in the postcranial skeleton, and this would confirm the diagnosis of the fibrous dysplasia. Whereas ossifying fibroma is a well-circumscribed process that may be radiolytic or may have some degree of associated radiodensity. The expansile and the well-defined growth pattern of this lesion in the absence of other lesions in the skeleton is the most important diagnostic feature. So that's why you have to be very, very aware and in touch with your radiologist colleagues and with your surgeon colleagues, whereas osseous dysplasia is best associated with the root of the tooth. And the lesions may be focal or could be multifocal, which obviously we are going to discuss down the lane. Now, diagnostic errors can arise, resulting in therapeutic and obvious prognostic repercussions. So some authors consider that histopathological diagnosis without clinical and radiographic correlation only becomes possible if biopsy specimen includes interface between lesional and normal adjacent tissue. But nevertheless, they acknowledge that this is a very rare occurrence on our tables. We hardly get what is optimal specimens. So the trouble starts. Now, most frequently, in the absence of the adequate clinical and radiological information, believe me, we've had cases where the OPG was also not done for the case. The pathologist will decline. So normally it's very difficult, and we give a very broad diagnosis of a benign fibro-osseous lesions, which is unfortunately for the clinician, this non-specific diagnosis does not provide much guidance towards the proper treatment course, which leads to problems. So briefly, we'll go through the three categories. The fibrous dysplasia, which we all know is a developmental tumor-like condition and is characterized by replacement of normal bone by excessive proliferation of cellular fibrous connective tissue, which is intermixed with irregular bony trabeculae. They thought early on that it's a hematomatous anomaly, and there has been some research where people have not agreed to it, so this is controversial. And fibrous dysplasia is a benign dysplastic process of altered osteogenesis, and we know it could involve a single bone or multiple bones, in that case it is called polystotic. And this is a disorder which is characterized by progressive replacement of normal bone elements by the fibrous tissue. And it is a bone tumor that, although benign, and it could cause significant cosmetic and functional disturbance, especially in case of, I'll show you an example of a polystotic fibrous dysplasia, which had caused massive disfigurement and obvious and functional disturbance. The patient had a limp. And this is the historical view from in 1891 when von Recklinghausen called it an osteitis fibrosa generalisata, to 1922 when Wieland described the first case in Europe, to Albright and his associated, they gave 5 cases of a syndrome of in which they said they showed the association of areas of pigmentation and endocrine dysfunction with precocious puberty in females. And then Lichtenstein reported similar findings and employed the term we all know, fibrous dysplasia of bone, and we've stuck to this term hence. And we know for etiopathogenesis, it is the NAS1 gene, guanine nucleotide binding protein, alpha stimulating polypeptide 1, and it may be localized only in one bone or diffuse involving multiple bones, depending upon the presentation of the mutation, at what time this mutation presents. And if the mutation occurs in early embryonic life, then osteoblasts, melanocytes, and endocrine cells, so are affected. So you have multiple bone lesions, cutaneous pigmentation, and endocrine abnormalities. And the late embryonic life, only osteoblasts are affected, but you'll get multiple bone lesions of fibrous dysplasia only. Whereas in the postnatal life, only osteoblasts are affected and you have fibrous dysplasia of a single bone. So an alteration in the transcription and expression of several downstream target genes, for example, the CFOS and a proto-oncogene, clonal chromosomal aberrations have been identified in fibrous dysplasia. However, the only recurrent changes reported to date include structural 12p13q changes and trisomy 2. So like I'd already said, it's monostotic or polystotic, and about 3 to 5% of polystotic fibrous dysplasia may be associated with the extraosseous manifestations. And these are the 3 variants, the McCune-Albright, in which you have a clinical triad of polystotic fibrous dysplasia with skin hyperpigmentation, the typical cafe au lait spots, and multiple endocrinopathies. The Jeff-Lichtenstein, which is polystotic fibrous dysplasia with patches of skin pigmentation, but no endocrinal abnormalities. And the Mesobrod syndrome, in which you have intramuscular myxomas along with the polystotic fibrous dysplasia. Now, overall, 25% of all fibrous dysplasias and 35% of all the patients with the MAS exhibit maxillary and mandibular involvement. And mandibular lesions may be monostotic, but the term craniofacial, I think we all know, fibrous dysplasia, is used to describe fibrous dysplasia of the maxillary bone, because often the maxillary sinus and adjacent bones are also involved, such as zygoma, sphenoid, temporal, orbital, nasal, frontal, and occipital. And the ratio of occurrence of polystotic to monostotic is 3:7. Now, this is our case, and you can see the slight bulge present here. And this is the case of a monostotic fibrous dysplasia, which presented in our department. And approximately 80 to 85% are monostotic. And most frequently, it's found in younger age group of 10 to 30 years. And equal male to female predilection. And the degree of bone is relatively less, deformity is less as compared to the polystotic type. So it's a painless swelling, asymptomatic, slow progressive bone enlargement. Maxilla is involved more than the mandible. Females are affected more frequently. And 50% of patients with polystotic disease and 10% of patients with monostotic have craniofacial, and that's our area of interest. And maxilla, zygoma, sphenoid, and temporal bones may be affected. So these are the other clinical features which I think are already, we are aware: facial deformity, visual impairment because of the optic nerve compression, exophthalmos, blindness, tinnitus. And now we come to the polystotic fibrous dysplasia. Now, this happens if the mutation occurs in the 6th week of intrauterine life, and comprises 20 to 30% of the lesions. The number of bones involved varies from few to almost 75% of the entire skeleton. So basically, the skeleton burden has to be calculated. There's a formula for that. And it involves skull and facial bones, pelvis, spine, ribs, upper extremities, lumbar spine, clavicles, and cervical spine, and may be unilateral or bilateral. So this is a typical 1891 from the monographs of Ben Ricklehersen. And this is a polystotic, and you can see there is a bowing of the legs, and which obviously would the patient would have encountered difficulty in walking. Now, 2/3 of the patients are symptomatic before 10 years of age. And in this, there is pain in the involved limb, limping, and spontaneous fractures. And 70% of the cases, there is leg length discrepancy with weakened structure and bowing of long bones. And there's a typical shepherd crooks deformity, which is curvature of femoral neck and proximal shaft of femur, which I'll show you in the case that presented to us. And these are the oral manifestations: expansion and deformity of jaws, intraoral pigmented lesions may occur, teeth may undergo tipping, disturbed eruption patterns, and mucosa is intact and may be tender on palpation. So radiographic features, usually it blends into the normal trabecular pattern. These are the borders. And in the early stage, it's unilocular or multilocular radiolucency. And then you have an intermediate stage in which you have mottled radiopacity or ground glass, or extraoral, you have a typical orange peel or intraoral radiographs, which I'll show you in fibrous dysplasia in my further slides. And then later it becomes dense radiopacity, and outline of the expanded bone is fusiform. So this is a typical appearance, and this is the ground glass appearance. The fine trabecular appearance is known as ground glass. And another thing noticeable is lamina dura is absent. So this is a mottled radiographic pattern, and demarcated finely granular radiopacity. This is less common. And this is the typical pewdy orange appearance, and there is absence of lamina dura. Another case in which ground glass and pewdy orange are both present on the standard occlusion image. And the pathognomic feature of the fibrous dysplasia is the superior displacement of the mandibular canal. And this is due to epicenter of the lesion is below the canal. Now, this is one of the very important features. That's where's the epicenter between a fibrous dysplasia and the osseous dysplasias, the cemento-osseous dysplasia. So the epicenter here in this case is below the mandibular canal, and lamina dura may be replaced with abnormal bone of the lesion, and PDL space is usually narrowed. So CT is the choice for diagnosis and follow-up because superior bone detail and this accurate assessment of extent of lesion. Furthermore, CT can also assist with differentiating fibrous dysplasia from other osteodystrophies of skull base, including osteosclerosis, osteogenesis imperfecta, Paget's disease, and osteopetrosis. So this is an irregular surface of both buccal and lingual cortical plates. You can see the irregularity on both the sides. And this is the more extensive involvement of fibrous dysplasia. It involves the medullary bone, cortical plates, lamina dura, and periosteum may or may not be involved. So this is a case which was published in JMFP, and the R.M. Mathur award was given for the best, case report. And this is a case which is very, very extensive case of polystotic fibrous dysplasia. So we started with, referred by my father-in-law, and we started with conventional radiography. And you can see the X-ray of PNS phase showing widened skull base and in the right frontal region. And then you have obliteration of the paranasal sinuses. Then you see the lateral skull view, and you can see diffuse sclerosis, thickening of skull vault, and frontal bossing. And then you have a PA view skull, which shows obliteration of frontal and ethmoidal sinuses, and this diffuse ground glass appearance. And here you have an exophytic lesion in the right mandible. So this is what the coxa vara deformity I was talking about. It's a shepherd crook deformity. Lateral bowing is seen and lesion, but has the whole bone is involved, but there's a sclerotic rim. And this is the left hip joint, and pelvis is also involved, though the right is normal. And here you can see the X-ray chest showing multiple expansile lytic lesions involving interior and posterior ends of ribs. You can see this, they are involved. So the conventional tomography was attempted because this was an extensive lesion in which needed orthopedic intervention. So he's an enlarged mandibular ramus and occipital bone, and the basosphenoid had a cotton wool appearance. You can see that, and thickened frontal and parietal bones. And you can see this is thickening as compared to the vault. Plain CT axial bone window showed enlarged occipital and left mastoid. And then you had a very typical exophytic lesion on the right mandibular ramus. And here you have obliteration of the right ethmoidal sinus. So we did a 3D volume rendered images of the skull and face to assess the bone deformity. And you can see expansile lesion of the mandible and the left mastoid here. And then you can see erosions on the skull vault and expansion of the mandible and the parietal bones. So this is another views, left cranium. You can see extensive lesions, and this is right cranium, and you have changes on the right side of the vault, and you have thickening of the frontal bones, and you have the overgrowth of the external occipital protuberance. Now, this was an extensively involved case, and when we did the blood investigations, we saw that FSH hormone was increased and serum alkaline phosphatase was 427, which was exponentially raised. Now, differential diagnosis, of the polystotic could be a Paget's, low-grade osteosarcoma, osteoblastoma, osteodosteoma, cementoblastoma, chirubism, aneurysmal bone cyst, central giant cell granuloma, or renal osteodystrophies, and cemento-ossifying fibromas. So laboratory findings, significant change in serum calcium phosphorus. In our case, they were normal, and occasionally raised serum alkaline phosphatase, moderately elevated BMR, and premature secretion of the follicle stimulating hormone. We know the histopathology. We know that it has a typical Chinese lettered appearance. We have metaplastic bony trabeculae in different patterns, and evenly spaced trabeculae of coarse woven immature bone. And the lesional bone fuses directly with normal bone. This is very, very important. And there's no capsule or line of demarcation. Now, this shows the spectrum of the fibro-osseous lesions. And you can see the typical curvilinear branches of the Chinese letter, what we love to say within the fibrous stroma. And at higher view, trabeculae of immature woven bone are devoid of the plump lining osteoblastic layer and this bland stromal cells. And here you have the trabeculae are merging with the normal bone. And then you have the round cementoid bodies. They could occasionally occur in the craniofacial skeleton. And here you have high power, which shows retracted osteoblast or stromal cells and exhibit continuity of collagen fibers. So this is the combined bone. And then you have the polarization, which accentuates the woven bone nature of the trabeculae and the sharpest fibers. There could be focal fatty changes and areas of chondroid metaplasia. So this is again, I'm reiterating what I said, that there is, just to give a bigger image, and here you have fusion of the lesion with the normal bone and irregular shaped bony trabeculae. And also what is appreciable is the artifactual separation of bony trabeculae from the surrounding fibrous tissue. And the hallmark of fibrous dysplasia, its inability of the tissue at the affected site to produce the mature lamellar bone. This is the mature lamellar bone. You can see parallel bundles. And in this case, this is a woven bone. And the difference of the two is appreciated during using the polarized light. And the bone formation is metaplastic process from the fibrous stroma rather than rows of osteoblasts forming the lamellar bone. So the two important differential diagnoses include low-grade osteosarcoma, which is characterized by infiltrative growth pattern, and mild cellular atypia. And bony spicules are often rimmed by mildly atypical osteoblasts, which is not the case in fibrous dysplasia. And osteofibrous dysplasia can be ruled out based on intracortical location and orderly osteoblastic rimming of the bony spicule. So this, I have never encountered an osteofibrous dysplasia, but yes, well-differentiated or a low-grade osteosarcoma should be kept in mind. And malignant changes with fibrous, this is tricky, include osteosarcoma, fibrosarcoma, chondrosarcoma, Ewing sarcoma, and the MFH, which is a trash bag diagnosis now. So treatment, I will not delve into, is conservative and various treatments like vitamin D and bisphosphonates. So now we come to cemento. I realize that I hope I'm not exceeding my time, and I have another 15 minutes to complete my presentation. So the cemento-osseous dysplasias occur in tooth-bearing areas, and the most common fibro-osseous lesion, they may be periodontal origin or represent a defect in extra-ligamentary bone remodeling that may be triggered by the underlying hormonal imbalance or the local factors. We all know this. So there are three types: focal, periapical, and florid. Focal has a single site involvement, periapical multiple focal involvement, but primarily in the interior teeth. And multifocal is anterior mandible, posterior portions. This is quite and synchronous development of anterior mandible. This is asymptomatic. This is in white females, 3rd to 6th decade. This is again in black females, 3rd to 5th decade, and affect black females in middle ages. So this is completely radiolucent. Now these have phases. The early lesions are radiolucent, and then they're densely radiopaque, and then they could be, most commonly it's mixed radiopaque and radiolucent. Early lesions are circumscribed radiolucency, and mature have mixed radiolucent and radiopaque. Now these are predominantly radiolucent, with time become mixed, and they have only a thin peripheral radiolucent rim because otherwise it's predominantly radiopaque. So this is well defined, but borders are usually irregular. This one is circumscribed dense calcification surrounded by narrow radiolucent rim and intact periodontal ligament space. This is very important because fusion to tooth is not seen. Now this is totally radiopaque and blends with adjacent normal appearing bone. So this is a case of focal cemento-osseous dysplasia, very typical. It's taken from Nebel, and we have been seeing this image for the longest time. And this is initially it was there, and as it matured, it became mixed radiolucent radiopaque. And this is our case in which we thought it was a residual cyst. But when we curated, we found that there was, we had a gritty hemorrhagic lesion, and these pieces were there. And this is what we encountered. So we had a bland stroma, and there was hemorrhage, and we had curvilinear bone here. So there was no inflammation, and we diagnosed it as focal cemento-osseous dysplasia, which was masquerading as a residual cyst. So the lesion that I want to concentrate is a florid cemento-osseous dysplasia, which was described by Melrose for the first time in 1976 and refers to a group of fibro-osseous exuberant lesion, and it involves multiple quadrants of jaws. And so there were certain jaw lesions, it could be very similar to the familial gigentiform cementoma, and you have to differentiate which. Now, familial gigentiform cementoma is an autosomal dominant genetic trait and affects mostly children. And the lesion is multi-quadrant expansile feature, affects both the jaws, often crosses midline, produces asymmetry and facial disfigurement. And the overall behavior of the familial giganticiform cementoma is like a benign neoplasm. It necessitates surgical intervention, which is otherwise contraindicated in the asymptomatic fibro-cemento-osseous dysplasia, florid cemento-osseous dysplasia. And you have to be very careful to delineate. You have to keep this in mind when you're seeing a case of a florid cemento-osseous dysplasia. So now this is our case in which you can see the panoramic radiography. You can see diffuse lobular irregularly shaped radiopacities, or basically cotton wool throughout the alveolar process in both the quadrants, and multiple sclerotic masses with radiolucent margins, borders are often found in maxilla and mandible, and they're confined to the alveoli, and they're at the level corresponding to and above the inferior alveolar canal is here. So all this is happening above the inferior alveolar canal. Another case in which the patient had an expansile lesion which was non-tender, and the skin was intact. And this is the X-ray of the patient. And since the patient was pregnant, the biopsy was not taken. And you can see the teeth are displaced here, and multiple lesions are found. And this is the histopathology of the earlier lesion, in which you can see these globules. And this is the high power of the areas, which was really acellular, and anastomosing trabeculae are found, acellular anastomosing. And if we come to the histopathology, it's a cellular mesenchyme which is composed of spindle-shaped fibroblast and collagen fibers. Free hemorrhage is typically present in the background of woven bone, lamellar bone, and cementum-like particles, and proportion varies from case to case. Now, this is the gist of the histopathology of the cemento-osseous dysplasias. You have hemorrhagic foci, like I showed you in our case, and you have you have the early lesion with the fibro-osseous pattern. Then you have the mid-stage lesion in which there are more trabeculae, and here they are sclerotic bone. And here you have a typical ginger root or curvilinear confluent trabeculae, which is a hallmark of this lesion. What happened? Okay, so this is a curvilinear bony trabeculae, and we put a zoomed view of the slide. And this is these are also known as ginger roots in a hypercellular, very, very hypercellular fibrous tissue, and there is no osteoblastic rimming here. So this is the differential diagnosis: an odontome and an ameloblastic fibrodontome. It usually occurs in children and associated with impacted tooth, osteodosteoma and osteoblastoma, in which pain is dull and nocturnal, no pain in FCOD, and the CEOT and all these show expansion. FCOD doesn't show expansion. And Paget's disease is polystotic and raised alkaline phosphatase levels. So, you have to go through the series. You have to keep delineating the other lesions so that you come to a diagnosis of a florid cemento-osseous dysplasia. Now, the third entity, which I'm going to talk about, is the ossifying fibroma. It's a trioneoplasm origin from a odontogenic apparatus or periodontal ligament. And if cementum-like material is present predominantly, the term was cemento-ossifying fibroma. And the cell of origin is predominantly same, and now it's controversial in the new classification. So the different terms like ossifying fibroma, cemento-ossifying, and cementifying fibroma were coined. So this has a female predilection, and it's found in the mandibular, molar, premolar region, usually asymptomatic and encountered on routine radiography. Slow-growing expanding lesions. Larger lesions cause painless swellings, though we had a very large lesion, and that one is a controversial lesion, and rarely may cause facial asymmetry, pain, and paresthesia. Now, it is a well-defined radiolucency with sclerotic border. Depending upon the amount of calcified material, it could be radiolucent, mixed, or radiopaque. Root resorption or divergence of roots may be noted. And large ossifying, this is very typical, demonstrate a characteristic downward bowing of the inferior cortex of the mandible. So this is a case of ossifying fibroma. I'll quickly go through the cases. A young boy, and coronal CT, left maxillary sinus, floor of the orbit, and this is the excised lesion. Another lady which was diagnosed as, so this is a case given by a friend, an old surgeon from a tertiary care center. So this lady, the lesion was excised because anyways it had come out and was causing disfigurement. And this is a gruesome lesion. And this is the X-ray findings. And this was diagnosed as ossifying fibroma, which I don't know. I do not agree with this. I've asked for slides, but then COVID happened and did not receive them. So this case is still on my mind. Would like to go back and see, but you can see there are radiolucencies, radiopacities, multiple quadrant involvement, and let's see what this turns out to be eventually. So normally, unlike the focal osseous dysplasias, most ossifying fibromas do not show close association with roots of the teeth. And cytogenetics have been done, and which I'll be discussing further. And now this lesion histopathologically is well demarcated from surrounding bone, unlike fibrous dysplasia, and thus permitting relatively this easily separates, and grossly and macroscopically the may be present fibrous capsule may be present. Ossifying, they consist of fibrous tissue that exhibits various degrees of cellularity and contains mineralized material. The hard tissue portion may be in the form of trabeculae of osteoid and bone, or basophilic or poorly cellular spherules, which may resemble cementum. So the bony trabeculae mixture of woven, peripheral osteoid and osteoblastic rimming is present in this case, and peripheral brush borders that blends with adjacent connective tissue. Significant intra-lesional hemorrhage is unusual. It's not there. And variation, you have mineralized material produced may be helpful in distinguishing ossifying fibroma from fibrous dysplasia, which has a more uniform pattern of osseous differentiation. So this we've already said all that, but to just put it in a table. Now, before the final sclerotic stage, cementosseous dysplasia is easily fragmented, gritty, like we saw in the case, curated easily and does not separate cleanly, but this separates cleanly and removed in one large mass. This comes out as pieces. Trabeculae are scanty calcified, and they are these are more delicate, and they could have curvilinear shape or ginger root, lack osteoblastic rimming, whereas this has osteoblastic rimming. And I think we've always learned it. And in advanced stages, they could coalesce in sheets of, the typical ginger root and sheets of lamellar bone, cementum-like tissue. And there could be very little fibrostroma, like we saw it in one of the cases. It was almost fused sclerotic avascular masses with no, stroma. And then cementum like a irregular shape, these are more of void, and there is retraction like we saw. And in this case, there are brush borders, hemorrhage throughout, and this is only at the margin. Hope these are, helpful in distinguishing between the two lesions. And we have an entity called juvenile ossifying fibroma. We all know it's two patterns, normally in younger age group, trabecular and submamoid, and no significant sexual predilection in most instances. The neoplasms grow slowly and are well circumscribed. And now this I've tried to put it here. Trabeculae is in younger patients, 11 years approximately, and this is 22 years of age, and occurs in maxillary. This is frequently occurs outside the jaw, and 70% are orbital, frontal, and paranasal sinuses. Trabecular is irregular stands of highly cellular osteoid, and these are concentric laminated spherical ossicles, so typical submamoid structures, and lined by plump osteoblasts, and they blend into peripheral brush border, and they may undergo remodeling and form crescent shapes. And this is the computer tomography in a 12-year-old girl. And this is a typical trabecular juvenile ossifying fibroma. You have seams of osteoid and scattered irregularly. Occasional calcified spherules are also seen. And this is the submamoid juvenile ossifying fibroma, basophilic, acellular, round to ovoid, and they may resemble submama bodies. And the calcified spherules may be closely packed to one another with no intervening stroma. So another case that was referred to us from our this thing, a resection was received, and this is the closer view, and this is what we found, a typical semimamoid kind of a structure. Now, various attempts to distinguish and categorically specify each group of fibro-osseous lesions using clinico-pathological, we've done that radiological analysis, and now we come to molecular features. And we have to, there are two ways. One is to familiarize, like we've already done, with the characteristics of the fibro-osseous lesions, the individual entities, and do whatever attempt you can to distinguish between the various forms based on the laid out criteria by so many researchers. And the second is development of novel molecular based diagnostic tools, which are being worked. A lot of people, a lot of centers are working on it. So accurate diagnosis is critical for a simple reason. I'll dwell for 1 minute on this slide. Because one, fibrous dysplasia we know has some degree of malignant transformation, so we need to follow it up. Second, the ossifying fibroma may have a possible recurrence if it's not managed well, but it rarely turns malignant, whereas the cementosseous dysplasias rarely pose any major problem. But the florid cementosseous dysplasia, we have to be careful because there could be a recalcitrant osteomyelitis. So, these are the things we have to keep in mind when we are diagnosing a lesion. And so what clue are we giving to the clinician? So the dilemma is another changes to distinguish ossifying fibroma from cementosseous dysplasias because they share a lot of common features of histogenesis, characteristics, radiographic presentation, and the histological features. So I'll quickly go through them. Now there are a lot of research going on the advanced histological techniques in the fibro-osseous lesions. You have histochemical stains like PAS staining, and then you have silver impregnated reticulin stain, and potential to characterize the hard tissue components, woven bone and lamellar bone. And this is confirmed by display of brush border or feathery edges of woven bone, connecting intimately with connective tissue in fibrous dysplasia. And these are not seen in the trabeculae of the ossifying fibroma and cementosseous dysplasia. Then von Cossa stain, in which ossifying fibroma showed a stronger reaction by deeper staining. Mesentrichome showed a higher proportion of lamellar bone, which indicated ossifying fibroma. And modified tetrachrome ossifying fibroma and cementosseous dysplasia showed excellent display of parallel lamellated lines. And fibrous dysplasia had non-lamellated woven bone. Then you have a lot of study going on EGNORs, and centers have found higher mean score of EGNORs in ossifying fibroma compared to fibrous dysplasia. So obviously ossifying fibroma confirming its neoplastic component. And this is a study, I know there's a lot of busy text, but this is Tolleton Blue, which found that 42.3% of expressed fibrous connective tissue in fibrous dysplasia expressed strong Tolleton blue staining, whereas this difference was statistically different. And so they came to the conclusion that histomorphometric analysis with Tolleton blue may reduce diagnostic errors between ossifying fibroma and fibrous dysplasia, though I do not have any personal experience on this. And then there's PCNA, in which ossifying fibroma displays higher PCNA index, and the osteogenic protein markers like RUNX, and then you have DMP1, osteocalcin, osteopontin. They observe differences in bone formation and osteoblastic differentiation, and intense staining of osteocalcin and osteocalcin. It's the most numerous protein of bones and fibrous dysplasia compared to weak reaction of ossifying fibroma, but did not find any significant difference. And then molecular analysis of GSA1 mutations in fibrous dysplasia. This has emerged as a definitive means of differentiating between challenging cases of ossifying fibroma and the CODs and fibrous dysplasia. Now, despite all this, several research into these lesions and applications of special stains, these lesions still continue to be potential diagnostic dilemma between fibrous dysplasia and ossifying fibroma, and ossifying fibroma and the cementosseous dysplasias. So molecular differentiation, I know using the reverse qualitative polymerase chain reaction is great in identifying NAS1 gene, but it presents affordability and availability issues because in a country like India. And molecular cytogenetic analysis is still in its early stages and results are inconclusive. So to conclude, like fibro-osseous lesions present a diverse group of conditions in which clinical, radiographic, and histopathological diagnosis could be difficult to establish. Correlation between biological behavior and the clinical parameters and histopathological data is essential. And we have to be in consultation with the oral maxillofacial radiologist and our surgeon colleagues to know about the radiological findings and the intraoperative findings from the surgeon colleagues. And when biopsy is included, if possible, include the interface between lesional and the normal adjacent tissue, and pertinent radiographic information should be provided. If you don't have, please go ask for it. Achieving an accurate is of primordial importance because your treatment depends on this, and no intervention, because there's no intervention in some and there's rapid and occasionally aggressive action required for the juvenile ossifying fibromas. So with this, these are my references.
That was lovely. Thank you so much, Dr. Simarpreet. That was a great presentation. We have had some questions. So there is one which is from Dr. Akshay Trimukhe. It's a few literature differentiate between the peripheral ossifying fibroma being a reactive process, whereas the central lesion is referred to as a true neoplasm. Is such a distinction needed?
Yeah, because I think the treatment is entirely different because they have been the molecular studies also. There was hardly any ignores in the peripheral. So that is a way is not that aggressive a lesion, and the central could behave depending upon the various variants. So I think the distinguish is distinct. It is important to distinguish.
Yes. Thank you. And there is a question from Dr. Nilesh Kapadia. Is there a difference between fibrous dysplasia and low-grade fibromyxoid sarcoma?
See, I've already told you, of course, and there are various, I think I've already covered this in my talk extensively, that yes, there's a difference. And there are ways if, histologically, you're not able to make the different markers, the different modalities, and that is why the molecular, everything comes into action. And you have to employ everything together. And obviously the natures are also very different.
Thank you for being with us.
Thank you so
Yes,
much,
everything
Mandana.
always just comes together eventually. Thank you so much. And thank you, everybody. Have a great day. And please be back next week where we are going to have the first episode of Perspectives. And we have Dr. Chandrasekhar with us next week to share with us his experiences of many years. And that will be what we will be doing. Have a great day and come back.
Thank you.
Thank you.